Q&A and chat box and answer all the doubts of the student. Thank you very much for accepting the schedule in your tight schedule. Welcome and over to you.
Okay. First of all, thanks Professor Dr. Somshekhar for your kind introduction, and thanks to National Board of Examination for giving this opportunity. So, dear friends, today, we are going to talk on most commonly encountered topic about the stoma and the management of the day-to-day issues which we commonly encounter during the stoma care. So first, I will okay. So let us start with the something on the basics of stoma. Many times we should know this. What is stoma? First of all, it is a Latin word. The word ostium, which means the opening or mouth. So this is very important. Stoma is a derived from the Latin word, and the meaning is opening or mouth. So the intestinal stoma is one of the most common surgical procedures, and normally we need to make a opening on the surface of the abdominal wall. That is called exteriorization of the. If it is the small bowel is brought out, it is called as a ileostomy. If the large bowel is brought out, it is called as colostomy. So the first of all, the stoma is not a new thing, and even 1879, the German surgeon Baum he did the first diversion for a case of a rectosigmoid obstruction. So he was wanted to make the patient more palliative and bringing out the obstructed part proximal to the obstructed part so that patient can live. So this was the first successful surgery which happened in 1879. So that is at the little bit on the introduction part. So let us go in depth about each stomas. See, as a surgical oncologist, we should know there are specific indications, complications, and the effects of electrolyte imbalance and acid-base balance, and even when we do the urinary diversions also. So without knowing this, we are not entitled to assist or do the stoma. So that's a very basic thing. I just want to, everybody should understand. This is a very, very basic, commonly done operation. So let us come to what is called ileostomy. See, ileostomy, as the word itself indicates, it's the ileum, and normally the ileum has got a little output is directly related to the location. If the stoma is located more proximal, there is a less surface area for the electrolyte and water absorption. The consistency usually of the ileal output is usually they are soft or semi-solid or liquid form. So, however, can be affected in many such conditions where the food and fluid intake can alter and the output also might change. But we should also know that normal output of the ileostomy. See, ileostomy normally it will be less than a liter. So it varies from 500 to 700 ml, and on an average about 600 ml is the usual output. So whenever the output goes beyond 1.5 liters, then we call it as a high output. See, high output ileostomy is one of the semi-emergency condition where the patient has to be taken care and as an inpatient. So let us go a little more depth about the ileostomy. So the ileostomy, loop ileostomy, this is very commonly done procedure in our day-to-day practice. So normally the indications for this are suppose if you do a protective stoma, we need to protect the distal anastomosis so that we need to divert proximally in various conditions. It can be benign condition, malignant conditions. So suppose in case of if you do something called proctocolectomy where the coloanal anastomosis is there, you need to protect that by doing this loop. Most of the these loop ileostomies are done for a temporary diversions. So then fecal incontinence, Fournier's gangrene, and where there is a toxic coli, and then also in necrotizing fasciitis and chronic perianal sepsis. Then other indications, even in general surgeons are also doing more of these procedures in case of a accidental rectal trauma or sphincter injuries, or if there is any rectovaginal fistula, RVF or UVF, and many other complicated inflammatory conditions of the rectal region. And also, if you're not diverted, and then probably if you encounter anastomotic leak, the simplest way to bring out of this septic condition is to divert the by doing the temporary ileostomy. So if you go to the website www.anastomoticleak.com, so this website, if you just go in, it has got few parameters. Normally, in a settings, 7% of the anastomotic leaks is accepted. So, but because of the efficiency of surgeries, it can be less than that. But anything where if you are having your statistics shows more than 7%, then probably you need to look at which are all the specific indications where we need to start doing diversion. So if you look at major factors like gender, the male and female, if you put some numbers for this into these parameters into the Google, when you Google this website and you add some like BMI high more than 30, they have got a high risk. Patient who are on oral anticoagulants and with intraoperative complication, prolonged surgery, post RTCT, and where the edematous tissue, where you can't bear the mesorectal fascia properly, and multiple staples have been used, and if the protein or the levels are less than 7, or if the albumin is less than 2.5 or 2.6, like that. So these are all the specific indications where you need to start doing the temporary ileostomy in where you have done the low rectal cancer anastomosis. But of course, there are high volume centers who are doing more and more of these surgeries, probably with the improved result. Those leak rates are little less. But on an average, a hospital which has got more than 800 bed strength versus less than bed strength, it has shown that a lesser volume of surgery, lesser hospital bed strength, they found that the more we need to start doing more diversions. So coming to the loop end ileostomy indications, there are some specific where you need to look at end ileostomy, which are always the permanent one. Failure of ileal pouch anastomosis, because ileal pouch, once it leaks, it's very difficult to salvage these anastomosis. Then you need to do the permanent diversion, emergency colectomy and proctocolectomy. Any emergency situation arises, probably we should know that good end ileostomy will be life saving. Then massive bowel ischemia, total proctocolectomy in a case of FAP and HNPCC syndrome, where the entire up to the anal verge the disease is there. Then Lynch syndrome, where it's one of the condition where the patients need to do a prophylactic sort of a total proctocolectomy in these patients. Then patients who are ulcerative colitis, which is very refractive, and where you can't put the patient on medical line of management, probably surgery is the only choice, and then you need to even prophylactically, to avoid the development of malignancy, you need to do the total proctocolectomy with the end ileostomy. So these are all the specific indications. But coming to something called large bowel diversion, it's called as colostomy. And the normally retroperitoneal colon is difficult to bring out, especially the ascending colon, descending colon, and but the more intraperitoneal structures like sigmoid, or the right flexure of the transverse colon, or the left splenic flexure of the transverse colon, because they have got a mesentery and it is easy to bring out. Always these are all the preferred site of colostomy diversions. But there is something called, we should understand, double barrel colostomy. The name barrel itself indicates gun, where the two outings with when you fire the gun, you'll be two bullets coming out, something like that. So, and loop colostomy, where you need to put a Penrose drain and try to bring it out and suspend it and stitch it out, and then the end colostomy. So sigmoid colostomy and transverse colostomy are the most, as I told you already. But there is something called perineal colostomy. So this is See, this is not a very successful surgery because it's very difficult to fit the bags and into the perineal area. Because most of the time, it's something called a leaking bottom where you don't have any sphincter which controls or which where you can apply the bags, and it's very difficult. Patient when it sits and walk and all that, something like a seepage of stools, and this is not a very well accepted concept. But there is an entity where if you have got some option, the simple one is to do the perineal colostomy. So let us come to some specific indications for loop colostomy, which is of a temporary. Suppose unresectable, you open the, in an emergency condition, found that's a very badly stuck rectal growth, then you need to divert loop colostomy. And then protective stoma in a deep anterior rectal resection. Of course, the ileostomy is a choice, but we should know that something called even colostomy is also of choice. Then the radiation proctitis, then incontinence, complicated rectal carcinoma with stenosis, then complex perineal fistulas in setting of inflammatory process. So coming to something called end colostomy indications. So here rectal resections with no restoration of continuity in below peritoneal reflections, malignancy, and perforating diverticulitis with fecal peritonitis. And there is one entity which we commonly do in a very, very, very low placed rectal cancer, that is called as abdominoperineal resection, where the end colostomy is of a choice. But coming to something, we see normally we encounter in 99% of our regular practice the adult, but there is something called pediatric stomas. These pediatric stomas are very, very important, but you need to understand most of them are developmental anomalies where it's a congenital malformations. For example, if you look at the Hirschsprung's disease, where there is a ganglionic segment of the colorectal area where we need to do the diversion. Then also there is a atresia of the anal canal and all that. Then if there is a developmental deficiency of the bladder, then you need to do something called where there is a bladder deficiency of the anterior abdominal wall. Coming to most important for us is more of theoretical thing is about urinary diversions. So in exams, please remember these diversions procedures are commonly asked. It can be a long question, and so we need to know we have to write the types of diversion. Okay, ileal diversion, colon diversion, urinary diversion, and also you can also mention like the purpose, like temporary diversions or permanent diversions and all that. So coming to urinary diversions, as you know that most of these, the ureters are brought out to the abdominal wall as a cutaneous ureterostomy, or implanted into the small bowel or large bowel. Based on that, we call it as ileal conduit or colonic conduit, or a continent diversions, where you create a pouch and make it as a continent diversion. Either a patient put a intermittent self-catheterization, or patient can void by himself. In that, we have got some subtypes called as Cox pouch or Indiana pouch and ileal neobladder and metro Fanoff procedures. So let us look at Cox pouch. It's a small intestine and to make valves, and the pouch with the outlet. Indiana pouch is where they will use a large intestine pouch and tissue from the small intestine. We use it as a distal part of the ileocecal junction to use it as a outlet. So ileal neobladder is a commonly done procedure for a continent diversion, and so here urine passes through the urethra. So natural via voiding will be through the via naturalis. So this is also one of the ileal neobladder. So let us come to some specific indications where we do the urostomy. So if you look at urostomy, common indications are, when you do the CA bladder, where you do the cystectomy, or there is a traumatic injury to the bladder, or incontinence, and sometime overactive bladder, and congenital abnormalities, then conversion of continent urinary diversion to incontinent stoma, then neurological diseases, and there is a spinal transection of the spinal cord, or the metastasis involving the spinal cord and pressing on the nerves, and chronic inflammation of bladder, then interstitial cystitis, radiation damage, and continent urinary diversions or neobladder. So whenever we talk about ostomy, there is always, you should know the other side of the coin, where whenever we say that the patient has to undergo stoma, there are a lot of issues. We as a surgeon, we should know that not only the physical issues, but there are also social and mental well-being issues which comes into the practice. This all indirectly reflects to the quality of life. So the normal effects of stoma, whenever we do the ostomy, major changes in the thing, biological changes which happens in the body. This can be related to the hygiene or diet or bowel function. So psychological changes are basically the less self-esteem, and then the patient disfigurement, and unable to attend some social meetings, and unable to carry out the bag, and so many other issues. So in a nutshell, we should, as a surgeon, we should try to address all this issue. It's not the physical issue. There is something called as biological changes which happens in the body that has to be addressed in total. So coming to, as a clinician, we should know that something, these issues should not be, never be ignored in our day-to-day practice. So overall, the comprehensive care of the stoma is very, very important. But there are something, lot of background effects which happens to the male or the female patients. They are all mainly, something called as pathophysiological changes which happens to the individual whenever we say that the stoma has to be done, especially whenever we say that permanent stoma. So among them, the major things are anger, anxiety, fear, traumatic experience, fecal incompetent, uncertainty, nervousness, aggressive behavior, conflict, isolation, stigma, frustrate and helpless, suicidal tendency. I had one patient where we were supposed to go for a abdominoperineal resection, where patient has completed the neoadjuvant RTCT, and over a period of 8 to 11 weeks we did the scan and MRI, excellent response. But he was just 2 days before the surgery, I got a call from the attender telling that he's no more. Then the drawback was, when we go in depth and find out it, we saw that he was not counseled, and he has been not been told about how to live with the stoma and all that. So in my practice, this was a disaster which I can never forget. So always do the proper counseling, so that patient had committed his suicide, and he was unable to available for surgery. So this was the one of the worst thing that which can happen to any clinician if you don't counsel the patients. So what is the problem in counseling? Is it you don't have time, or is it you don't have interest or ready to spend more time with the patients, and or is it lack of manpower? So these are all the issues which I came to my mind when I went through. But there are some solutions. Most important thing is that pre-operative communication, pre-operative education, then is the most important. That's why something called as what is exist is the teamwork. So there is a beautiful article which has come from the Denmark. This is a little in the year 2017. So this article clearly says that the educational activities aim to increase in knowledge and focusing on patient psychosocial needs may lead to raise in the health related quality of life. When patients with a stoma attend a structured patient education program, it is possible to improve their health related quality of life compared to the patient with a stoma who do not attend the program. So this clearly indicates that the patients who are educated and takes a little better and little more acceptance will be good if you counsel the patients this one. So first 6 months are the very crucial time where you need to be aware that they need a time to adjust. So who will counsel the patient? That is the next question which comes. You yourself will do it, or your stoma therapist? If it's a comprehensive care in a good colorectal unit where you need to have something called as stoma therapist, stoma nurse, or psychologist, or something, a background of oncologist, psycho-oncologist, or a patient who has already undergone the surgery, there becomes advocate, who are survivors, we call it as advocates. So these patients can counsel, and all of them are can can be a part of the entire teamwork, or one of them can take a lead and counsel the patient. So in a nutshell, together everyone achieves more. That's a very, very important. So in our practice, we should also know that whenever, see, I say that this patient need to undergo the stoma, then I counsel, but probably I'll not be going to the grassroots level and I'll not be touching the patient needs. So that's why these patients are, lost for our practice. Then basically, whenever we post for surgery and they don't turn up, that indicates clearly that you have not convinced the patient, and the oncological results we get, how we can tackle and improve the patient local recurrence survival, and all that is an important factor. But whenever we counsel that, most of the time the female patient dropouts are higher compared to the male patient. This is my close observations which I have done through almost like 2.5 decades. Then the other issues comes, normally the other part will be cost of bags, that is the economy part. Then whenever we say temporary, we close it after 6 weeks, 12 weeks, and or 3 months, the patient acceptance is good. But whenever we say that it's a permanent stoma, there are something that they don't accept well, easily and well. So these issues has to be dealt properly. But there is something called, we do something called a low anterior resection or ultra low anterior resection, or something called intersphincteric resection or coloanal anastomosis. So this is all the recent advances which has happened. There is something coming out called as total neoadjuvant treatment, where you can, if the patient has got a good pathological response and all that, we can have to do something called as wait and watch policy, or sometime even if it recurs without altering the outcome overall survival, we can go for a salvage surgery. But also the important is that we need to get a good biological result by preserving the autonomic nerve preservation, where it will provide it will preserve the bladder functions, and the and also the something like erectile dysfunctions are very less if you do the ANS thing. So just look at this. This is a ultra low anterior sections. So we need to bear the entire mesosigmoid, and this is a sure form of staple where we go up to the pelvic floor, and then this is a 180 degrees angulation is possible in a robotic sure form, and you staple it, and in one go, in one staple you complete the thing. So these are all the which has advancement which has taken up, and where we need the temporary diversion. But let us know something on what is called as stoma preparation, stoma, or the creation of stoma, or what are the normal complications we come across in our day-to-day practice, or how the stoma reversal has to be done. So let us look at, most important is that as per the guidelines, NABH or JCO guidelines, or even the hospital practice, good clinical practice, we need to always mark the stoma. So normally, the ideally is through the rectus muscle, very, very important. It should not be on the lateral border of rectus muscle, and then the risk of relapse and parastomal hernias are very, very less. The most prominent, part of the diversion is when the patient stands, and you look at when the patient looks from the top, the most part which is seen is the one which has to be looked for the diversion. Normally in the spinoumbilical line, little more towards the midline, along the rectus muscle we need to do, but not along the spinoumbilical, little above, because but there are specific which I am going to come little bit. I'll show some pictures also, and where we need to do the different location of stoma in obese individuals. Most important that bony prominence should not be there, because normally we need to have a square place where the backs fit very well, and where the bony the bone doesn't come in the way of application of these backs. So look at this patient. She's a very hardworking laborer, and she does a lot of physical activities, and you look at that, she's very comfortable, and she has got a good appliance, and the most important is that in a obese individual with a pot belly and all that, the stoma should not be looking towards the ground with the angulation. Stoma should be facing anteriorly. So that's very, very important. So the apex of the infraumbilical fold fat is the most important, commonly preferred site for these diversions. So the common problem associated with the stoma, as we found that in the preoperative thing, it is anxiety and some amount of depression. And also in the first few weeks, the patient will have, also we need to educate that post diversion, the patient will have something like a phantom rectum. They still have that urge to pass the stools, and they keep on telling that I feel uncomfortable in the perineal floor after the permanent diversions or even temporary diversion. Then the consistency of stool also has to be told. Then most of the time the liquid or the gas leakage and seepage is very common, but that has to be also we should be told. And about the allergic reactions because of the bags and all that also has to be told. Then risk of dehydration, especially in a high output fistula, there is a lot of things like dehydration which can come up. Then bleeding during the bag change also one of the, and then prolapse, narrowing or blockage of the stomach can occur. Stenosis and then ribbon like stools and excessive high pitched wind will also require some corrections. But whenever a patient travels through air, there can be a cabin pressure change. All this patient also has to be explained. There can be some changes with the gas coming out at the bag and all that. That has to be educated. Weight loss and gain can affect the function of sometimes because of the body physics. So coming to a few complications which we commonly come across is ostomy prolapse, ostomy stenosis, parastomal hernia, cutaneous irritation, ostomy retraction, then obstruction, ostomy ischemia necrosis or other necrosis, fluid and electrolyte imbalance, hemorrhage, hematoma, fistula. So let us look at one by one for in a little quicker with a, you can look at these pictures. So this patient has got a temporary ileal diversion, but the patient is on taking 5FU based chemotherapy. You find that there is an angry looking mucosa and with a pyogenic granuloma at the edge. So this is a very, very common thing. Patient follow, you do the surgery, but patient tend to have a lot of mucositis with the 5FU based. This is another patient where you can look at the stoma is there, but there is a lot of excoriation of the skin because of the bile. Bile has got a lot of chemicals. Whenever it comes in contact with the surface of skin, they produce a excoriation which is very, very painful. And these patients have become more concerned about this skin excoriation rather than the disease itself. So there is something called as this contact dermatitis which happens in a lot of patients because of the application of the bag and the stoma paste what we apply around the disc side. This is a very commonly encountered in our practice, but there are something called as a different sort of paste, powder, or the spray available, or something where you can keep educating about how to change the disc, when to change, and all that. Probably by doing that, these are all the very comfortable bags. And there is something called as a convex bag where you, if the stoma is little deeper and not at the surface level, probably convex bags are very, very helpful. There is something we always look at, that ileostomy. When we do the diversion temporary, you need to put your finger on the operation table and look at the patency of the stoma at the level of the rectus sheath. Sometimes if these stomas can get narrowed out, especially the proximal limb has to be really patent. But we do have come across a patient where it's not admitting because of the massive edema or because of the flip of the at the peritoneal level. Sometimes we need to look at these, and patient will be comfortable. All the contents come just to stay proximal to this out ileostomy site, and then you will find that the patient is developing some sort of subaqueous obstruction. So we need to correct this with putting a small tube just to keep it patent, and then once the edema settles, the patient will start functioning regularly. So whenever we do the rounds, we need to tell all the juniors, undergraduates, postgraduates, and even the postdoctoral people, and also the junior consultant, always look at the stoma. Even if you're losing one disc, it's all right, but look at the edge periphery of the stoma. So when I did the rounds on the second day, I felt there was slight discoloration at the edge of the skin, and then when I did on the third day, we found that there is almost a cut through of the sutures and all that. So very very important, we need to look at in depth during round. So this patient had a bag which is very tightly fitting the disc. So suddenly patient had a prolapse, and the patient didn't notice this, something is coming out, not going, but he was not able to appreciate the color because the bag was there. And over a period of about a 12 to 16 hours, he came to suddenly OPD, and he opened the bag, and we found that the disc itself was like acting like constricting after the prolapse, and it has caused the necrosis of that segment. Then also we might have, whenever we come across emergency procedure where the stomas are dilated bowel, you divert it, and then you find that after 1 or 2 months the patient will having something called as prolapse. So always this happens in an emergency condition. So the colostomy prolapse is one of the things. So also you sometimes we notice that stomal retraction because of the, especially it happens in one of the very difficult to tackle, but that's why we should always take a measure, especially in an obese individual. So what is healthy stoma? See, we have seen a lot of pictures about the stomas which are not looking all right, but there is something called as a good stoma. It should be a red and moist stoma, and no gap between the skin edge and this one, and no redness, rash or ulceration or inflammation around the skin. So look at this. This is the a good healthy stoma, which is looking very fresh, and you have got a proper skin contact all around, and where you can cut the appropriate size of the disc and you can apply the bag. So look at this here. The normally whenever we divert the small bowel, at least 5 centimeters should project out from the surface of skin, especially in the ileostomy, and at least 2 centimeters in case of colostomy. So this is a very very important. Let us look at some more things where there is a stoma breakdown. See, there here you can see that all the contents of the diverted colostomy is going back into the subacute space and just above the rectus sheath. There is a complete breakdown, almost 3/8 of the circle of the entire skin breakdown, and there is a mismatch of the type of disc you take out, the skin, and the type of the size of the stoma. This once it cuts through, it's very difficult. This all happens with whenever you use too much of cautery, or whenever you take out denuded lot of skin, and then they can experience. This is a very common, very challenging for the surgeons. That's parastomal hernia, and this parastomal hernia is a very very challenging. I have failed many times in doing and correcting the parastomal hernia, but the most important is that there is something called as prophylactic mesh repair. If you are able to do it for a required high risk patient, you can do it, but it's not a very commonly done practice. And then sometime for that correction we need to relocate the stoma to other place and put a mesh and then redo the procedure. So but still there is a possibility of recurrence. So most important that we need to understand that parastomal hernias are not uncommon, they are common. Okay, the next point is that in nearly 4 patients of ileostomy, 1 patient is going to have some problem with the ileostomy, and in 4 patients of colostomy, 2 patients are going to have some problem with the colostomy. So that means that when something like 1/4 and 2/4 of the patients are going to have some problem with the type of diversions called ileostomy and colostomy respectively. But these patients can have something called prophylactic mesh. I will talk about this for high risk individuals, and no perfect operation has been described so far for the parastomal hernia repair, but we need to have, suppose whenever we correct do the parastomal hernia repair, sometime we might lose some bowel with the vascularity. We need to have a little more length of bowel coming out and reaching separately. So that's very important, and whenever you correct it, we need to look at with a laparoscopy if possible, try to release the adhesions and do the mesh repair. Then recurrence of hernia with mesh is also about 10%. So let us look at some of these risk factors. What are the risk factors for the development of hernia? One is obesity, malnutrition, advanced age, smoking, collagen abnormality, corticosteroid use, especially those patients. I have come across a patient with a post-renal transplant, with a burst abdomen, with a colostomy, parastomal hernia, and then also we have got something called wound sepsis because of the retraction. Then patient who are going to have progressive disease, ascites, abdominal distension, then some of these obstructive pulmonary disease like COPD, and these patients tend to have the parastomal hernia. Then surgical technical factors, inappropriate stoma site location, it's one itself is one of the factor. Then oversized facial atrophy, that is, you make a cruciate incision, sometime you make too big size or make one incision where the rectus sheath is not supporting, then this patient tend to have this one. And splitting of the muscle, like a like a star, you have to put the insert and two different direction you have to open the muscle. Then epigastric nerve denervation. Then whenever we, as I told you earlier, whenever we do the something called as emergency procedures, these patients tend to have some of this parastomal hernia. So let us look at something called risk evaluation. So what are the risk evaluation you need to do for the patient? So factors contributing to the development of parastomal hernia includes obesity, gender, age, the sighting of stoma, abdominal disc. So many other factors has been told already. There is something called as that early patient education regarding any and awareness for the potential for the parastomal hernia development, that it has to be really assessed in each individual. Then something called as abdominal exercise. So enterostomal therapist or the nurse can able to look at these factors. We need to educate, and in a teamwork they will be able to assess this. Then use of abdominal support belts while undertaking heavy lifting and heavy work for a 1 year post-operatively is also one of the risk factors. So we should also look at something called as what are the advices we need to give to the patient whenever post hospitalization, post discharge advice is very very important, that this has to be told in depth to the each patient, and sufficient time has to be given for explanation. What are the advices given to the patients and attendant, most important? Then the what are the advices the doctor has to convey to the stoma nurse, and in turn the stoma nurse conveying to the patient and the caregivers. Then also the role of community nurse. So let us look at the most post stoma discharge advice includes like this. This is very very important. So we segregate into two aspects: one, caregiver's responsibility, and the nurse's responsibility. So caregivers' responsibility is finding a well-fitted appliance. This is a very very important, that if there's a ill-fitted appliance, then the leakage, seepage, and excoriation and all this is a very very important complicated issues which can come. Once it starts, it's very very difficult to think. So first time best advice should be given, and then also maintaining the stoma hygiene. Sometimes these ill-fitted devices can cause sometime release of letters and very uncomfortable, and also something called as a hygiene part is very important. So stoma cleansing and then also skin protection is very important, and regular bag emptying, and then also we need to educate something on what is called as irrigation. Patients who have crossed more than 6 months and where is a properly done stoma, we can educate about the irrigation, especially those who are living with the permanent stomas. We need to educate. Then following the healthy also we need to advise something on the diet part and how much the fluid intake should happen in the different seasons and all that. So coming to the nurse's responsibility, train the new patients and caregivers. This is very very important. So nurses has to extend their work and also do a lot of education program and training, adding more new patients and their caregivers. So this is all a very what is called as community practice. Then also the nurses also should educate about the infections which can happen, irritation, on all that. So what the caregivers advise, same advice has to be carried out here also. Then leakage or poor addition and patients, how to, when to reach to the doctor, when the stoma therapist has to visit their house and all that. So and also they should report to the doctor or the nurses when there is a bleeding and other unusual symptoms. So let us look at what is the role of community nursing. Community nursing is a very important entity which is coming up of late. Is an interdisciplinary team member, acts like an interdisciplinary team member, provides a specialized knowledge or the skills, and training on stoma to patients and family, identification of complications of stoma, and supply of ostomy materials and other products, and showing a digital skills on a smartphone. So these are all the roles we have defined to the community nursing. So most important, another factor is that you should also know how to do the stoma closure. It can be either hand-sewn anastomosis or it can be a stapled anastomosis. If it's a hand-sewn anastomosis, always to freshen the edges of the stoma, and then also look at the vascularity, and then do the Lambert's suture, that inversion suture, and two layers of suture. One observable layer, one non-observable is preferred. And sometime, if the facilities are there, and if there is a staplers available, and you can do one vertical fire from the top to bottom, taking a stapler of 45 or 60 if it is endo stapler, or taking a 60, 80 or 55 or 75 stapler, and going vertically and transecting horizontally, something like a T fashion, the two staple, and so all these staple lines in a high risk patients, we need to reinforce the staple line. There is something called as success. So when we can say that success we have achieved, it is all at a different levels. Whenever you do the pre-operative education, and then we can achieve better results. And also the involvement of other health professional, it's very important to involve the paramedical staff. Then also, whenever the issues comes, they are all not permanent, they are all transient, but we should also give the patient reassurance that these are all for a transient and they can overcome it over a period of time. Then there is something where there is a more requirement. There is something called as stoma rehabilitation. This can be educated by at different levels. Then there is something called as psychotherapeutic intervention. They have got something. The physical relations with the spouse is the most important what we commonly encountered, and these patients, we have seen some patients coming out with a lot of viral infection around the stomach, skin, and all that. This is also entity which we are coming across in different the relations and all that. So these aspects has to be to be dealt, then only we can think about. So look at this very very young individual, and where he came to the OPD, and then he underwent a robotic abdominoperineal resection. Unmarried guy, and very active in his profession, and he's a he showed the stoma and his appliances very well fitted, and well covered with the garments, and nobody can feel that he has undergone the surgery. So many times whenever we treat the patient, but one of the patient recently messaged me that so this is a patient who had undergone the permanent diversion. So this patient has told her message. She has said and conveyed me like this. So this she also expressed that this has to be given and told to the other patients who are undergone the stoma. So she said that everyday life has changed. I had to be educated in changing the bag. Others around me had to learn also in case I need the help. It is not on demand she's seeking the help, but whenever she's not able to manage, she needs some help. But as long as we are here alive, as long as we have the willingness to live, we have memories, warm and supportive people next to us, then we must try to improve our lives. I want as much as possible to have a very beautiful and lively life, to have a good life, and I can see that over the years I can achieve this. So she has clearly mentioned every word, every sentence, whatever conveyed by her is a very, very, convey a lot of message that these are all shortcomings, and with a good management of teamwork and with a good winning the confidence of the patient, then we can achieve the best outcome. So as a surgeon, also I just try to take you little more into for a people who are not doing regularly to go how we have to do the this diversions. So this is a very important that whenever your boss gives a chance or something, please do the diversion. I have finished the resection and rest to do the diversion and close. So in a busy center where the your boss or the professor who has to go for other case, he will give the chance to you, and you should know that how to do this procedure. The main steps in creating the end ostomy are common in both ileostomy and colostomy. That's a very basic thing. First, a circular part of, if you are doing a permanent one, first a circular part of the skin with a diameter of 2.5 to 3 centimeters is removed and at a desirable site using a monopolar cautery. After being lifted using a Alice forceps or a Cocker forceps, then the anterior rectus sheath is exposed, and after the blunt dissection of overlying subcutaneous fat, then you need to give a cruciate cruciform incision. Cruciform is something you need to that something like a vertical and horizontal cut, that is called as cruciform. And see this 3 centimeter long limbs should not be a very big one, and underlying muscle fibers are bluntly divided with a pair of straight scissors or a Kelly clamp and safeguard the inferior epigastric vessel, which can be encountered. That is the most important. We should not injure that. Sometimes when we do stoma, we are not aware this there can be injury to this vessel. It can be cause a lot of bleeding in the postoperative time. Then posterior wall of rectus sheath is then revealed, and then vertical incision is made, dividing the parietal peritoneum. Now, proximal part of the divided bowel is, excuse me, proximal part of the divided bowel is then grasped with a Babcock forceps, and then you need to slowly exteriorize this bowel. The length of bowel ought to be protruding from the skin surface is 2 centimeter for colostomy and 5 for the ileostomy, which I already explained you. Then midline incision is then closed. Then maturation of stoma has to be done, and then this bowel has to be cut on the antimesenteric border, and then we need to anchor the this bowel to the rectus sheath and in one layer at 4 levels of sutures, and also to the mucocutaneous junction with a separate non-absorbable sutures. And then you need to have a outpouching some sort of for the ileum, and little more less for a colostomy, at least 2 centimeters. So coming to the ileostomy, which is much more commonly done nowadays because of the easy way of managing and closure of this stoma. Normally, the bowel loop should be at least 12 to 20 centimeter from the IC junction. Very, very important. See, you need all these temporary diversions has to be closed later. So the choosing the proper site of ileum is very, very important. So we need to go to the ileocecal junction. From there, proximally we need to calculate about 12 to 20. In a obese individual, we lose lot of bowel whenever we do closure. So that's why we need to take at least more than 20 centimeter in an obese individual. In a normal patients, about 12 to 20. Because when you go very close to ileum, I see lot of distal part of the ileum, about 4 to 5 centimeter of the ileum is always fixed, so it will not come out. So you leave that 4 centimeter and start calculating proximally about 12 or 20 centimeter depending on the requirement. So, but whenever you do more proximally, there is a high output possibility. That's a very, very important. You should not do into the mid ileum or in the ileal level. It's one of the disaster and which is very harmful to the patient. So next step is to create a small gap in the mesentery or mesocolon, and normally, preferably, we can use the infant feeding tube or Riles tube or the the suction ET tube suction tube, or we can use a small T tube with a cut piece of the T tube, and we can anchor the bowel to the. So just for about few days to avoid the retraction of the bowel. So the suture should be used to anchor this thing, and we need to label the which is proximal and which is the distal limb of the thing, at least by location, one which comes medial, lateral, or superior or inferior. So incision is made in the very important. Please note that the incision should be made in the anti-mesentery part of the bowel, because the mesentery is supplying the bowel almost up to the full circumference. So most important is that the anti-mesentery part we have to do the enterotomy, and you don't have to make 100% cut. It is the only should encompass. Suppose if the lumen is say 3 centimeter, 80% of this lumen if you open it is more than sufficient, where you can make a outpouching and then you can have a nice stoma coming out. So surgical care during stoma. Special care should be taken to ensure the viability of stoma. The bowel loop to be exercised ought to be adequately mobilized. Very, very important. It should not be having a traction and counter traction. See the skin level one traction and lower down weight and something where short mesentery it's pulling. That is one of the things. See the basic principle even for healing of anastomosis, everything is traction and counter traction has to be least. And most important that it should be well vascularized bowel. So the and also the tightness of the ring should be less. You should at least admit a little gap around the bowel so that the strangulation and venous congestion will not happen. And also that if it is too big, then there is something called prolapse, which we already saw that some pictures earlier. Then twisting and protruding of the bowel or at the mesentery can cause some the perfusion of the segment of the bowel and can. So it should come straight like a pillar from the mesentery to the top. Like a vertical thing, and there should not be any rotation. Too much angulation, too much rotation can cause venous thing. Arterial will be supplying, but venous is most important for the success. Whenever there is a back pressure, sometimes congestion can happen. So nowadays, of late, because of the good minimal invasive procedures which we have already seen and learned, and there is something these diversion can be, you can have accurate bowel location where you need to bring the small bowel. So by doing a laparoscopic or robotic surgeries, we can try to locate this and try to take out with the location of the stoma. So the stoma creation can also be performed by this MIS, and the advantages again will be as such. That because of the less handling, and the stoma might start functioning faster, better, and there can be rapid recovery, and you will be not much touching the vascularity of bowel, and it might look as like a fresh tissue even in the first 1 or 2 days. So that's very important. So we always should look for and do it for something called as a minimally invasive surgery. So let us. I will have one or two questions. So just look at and answer to me on the messages. See, 54-year-old man with ulcerative colitis was recently found to have pathologic evidence of dysplasia, and just let us. He has undergone some diversion. Okay, so that is something called totoproctocolectomy with an end ileostomy. Okay, which of the following is the most appropriate stomal site for patient? The answer number 1, at the level of the anterior superior iliac spine along the left abdomen. Choices A, B, C, D. Choice 2, inferior to the infracostal margin along the right abdomen. Okay. C, lateral to the rectus muscle along the right lower quadrant. And D, through the rectus muscle along the right lower quadrant. So please answer me in your chat box. I will see the answers. But I will also explain you why the other three answers are wrong. Okay, so I think I'm already getting a lot of answers. All answers are correct. That indicates that I have done some justification, and people are, able to understand me, and also able to understand my mind and what I'm expressing. And thank you for that. Okay, the next question. Another, for example. The 59-year-old man presents to emergency department for with 2 days of high stomal output greater than 1.5 liter following the formation of ileostomy. Which of the following is the best initial step in the management of this patient? A, B, C, D. First choice, oral water. Second choice, intravenous fluids. Third, C, stoma revision, and D, reassurance. I am getting a mixed answers, but I have got an answer. I am getting the mixed answer. So this is the one thing which I have not dealt, and so normally whenever there is a high output fistula, if it is a ileum and all that, the most of the fluid which we need to give it is the intravenous fluids. That is a choice of fluid which we need to give it for most of these patients, not the oral water. But if the purpose is not done, then you should never look for the stoma revision, because you have accepted, patient has accepted the stoma being done. There is nothing like stoma revision, because it has to do its purpose. Then only we can think of reassurance. Is not a choice, because it's a semi-emergency condition. How you can send the patient back with a reassuring and all that? So patient has to be made an inpatient, and we need to encourage and give more interparental fluids, IV fluids. That's the answer. So also we need to know this. We need to understand something called as colon physiology. Major role of the colon is water absorption, electrolyte exchange. This is a very very important thing, that this 500 milliequivalent of sodium can be absorbed daily in the colon under normal circumstances. Besides, the colon plays an essential role in absorption of other vitamins like vitamin K and B12 also. Same things happens in the smaller intestine. So stool consistency, left-sided colon, most of the time it is little formed, more formed stools, and especially all the colon will have little more formed stools compared to the liquid stools. So high output, I was telling about 1.5 liter. Management of high output. Let us see. Look at this. Exclude the something like a short bowel syndrome. So that we need to exclude in high output. It can be intermittent or small bowel obstructions. Also, we need to look at that. Stoma content is about 100. You need to look at the sodium content in the stoma, then rehydrate, thus treat the thirst, and restrict the hypotonic liquid fluid like tea, coffee, water, juices has to be restricted. And oral glucose saline solution. If the magnesium is level, you need to look at the magnesium correction. And so the isoosmolar has to be is a choice, and the loperamide is another drug which we can use to TID and all that. Omeprazole is a one important drug where you can reduce the stoma output, and then that is a very commonly prescribed medicines. Then also you need to look at and correct the magnesium. So the high output management, patient with high output need to assess for the fluid status and given intravenous fluid resuscitation as an appropriate. Anti-motility drugs like loperamide can reduce the stoma output. Drinking the excessive hypotonic liquid like water, tea, and other juices and drinks can increase the stoma output, causes the patient to be more dehydrated. Now this slide I have put it little later because I asked the question, but many answers came little wrong. So this is the answer for that question, that you need to have IV fluids. So high stoma output, loosely defined as more than 1.5 liters every 24 hours for 2 consecutive days. Then only it is called as thing, but it can indirectly causes harm by doing the acute injury. And coming to the last few slides, the when not to do stoma is also very important. There are, something absolute contraindication are not there, but there is something like whenever you feel that carcinomatosis. Carcinomatosis is a condition where there is a shortening of mesentery, too much of seedling of deposits on the mesentery that can cause short mesentery, and you can't bring it. I told you that it should be having a good mesentery to bring it out. Then inadequate length of mesentery it disables the free tension and then formation of the stoma. Tension on the stoma, which is more common in obese patients, is an independent risk factor for developing stoma complications. So, in an obese individual, always your boss himself is more experienced. He should do it rather than the juniors. That's very important. So, because all problems in obese individuals we do come across. There is something called as ERAS. ERAS is enhanced recovery after surgery, and we tend to apply this ERAS protocol in most of the stoma management. So post-discharge, this is a little more pictorial to view to the patients and the doctors. In general, stoma should be normal looking. If the stoma becomes more purple color or black or white, they have to report to doctor. Or if there is a severe cramps lasting for more than 6 hours, then they have to report to doctor. Severe watery discharge from the stoma. No output for stoma for 3 days. Now we have to report to the doctor. Excessive bleeding from the stoma, they have to report to doctor. Sometime in a patient with a portal hypertension, you have done a good stoma. There can be something more venous pressure because of the portal pressure. Then there can be congestion on the stoma, and then the color can change. The stoma pulled inward below the skin. Again, I told you, if anything retraction happens, there can be a pulling of the contents and causes the problem, and severe irritation of the skin. This is also one of the things. So most of the time, patient asks, doctor, what diet I have to take? Most patient will be advised a normal diet depending on the type of stoma. Some may be advised a modification in eating habits and control and frequency, consistency of bowel movements. Average daily output, as already mentioned that. So those are all the important factors. Coming to few aspects of urinary diversions, because this can be a short note question or long questions, or even in your Viva OC, whenever the instrument is given for stapler or something, they will ask specific indications for diversions. So coming to urinary diversions, there is a metabolic complications can happen. Altered bowel function, malabsorption, acid-base balance, electrolyte abnormalities, bone demineralization. Patients who are surviving with the urinary diversion for long time have formation of calculi, renal and hepatic function impairment, and then drug metabolism changes. So coming to acid-base electrolyte changes, hyperchloremic metabolic acidosis. This is a very, very common whenever we divert to the ileal diversion. So there can be, the thing is, sodium is secreted and exchange of hydrogen and bicarbonate access. That's why acidosis can happen, and hyperchloremic. So there can be the chloride exchange can happen with the sodium. And the median follow-up is 1 year. We found that 10% of patients with ileal conduit have some metabolic acidosis, which is severe. That's why we give a soda mint or soda bicarbonate tablets. Then, so all these patients should have, managed properly with 1 to 2 gram at 3 times a daily. Then mobilization of the carbonate results in a calcium release from the bone, and so then these patients tend to have hypocalcemia, and calcium supplement or also has to be supplemented. Post diversion, whenever we use the ileum, there can be vitamin B12 deficiency, and then the urine phosphate and all that stone formation thing. So never use non-absorbable suture that acts like irritant, and stone formations are very high. Hypomagnesemia is a rare condition, but it's not a thing. So to at a completion, the take-home message is that most of the stoma is created in an emergency sitting rather than the elective sitting. So all these emergencies conditions where the junior level of doctors are involved, they have to be educated, they have to be trained properly, number one. Number two, that nearly two-thirds of stomas will have some kind of complication. Now you have seen that, different variety, A to Z, different side of complication, different types of problems they face, that you need to understand. Early identification of complication will reduce the morbidity and mortality. This is in general for every, surgery, everything. So that, but we need to identify and correct it. In recent days, most of the stoma is created for malignancy rather than infectious disease. Malignancy also incidence increasing, prevalence is increasing. Then so these indications are also going up, and also that's why the malignancies are more common. Stoma care should be given by a multidisciplinary team, including surgeon, primary care physician, stoma nurse, and stoma therapist. So thank you for patient hearing. So I will stop sharing now. So can I? Okay, I will go to the chat box now. So from Suryakant Jai Singh to panelist. From okay, you have answered very well. Good. So that is the answer. Almost all answers are correct. First question. So the second question, the answers are variable. So that I have explained in depth. So I have done. Okay. So there is a question from Dr. Rakesh. Good morning, sir. How you manage the skin excoriation around stoma? What things one should be keep in mind to increase the bag fitting in such conditions? Very good question. It's a very practical question. I really, I wanted to go in depth about this. See, most important is that, if you take a proper intraoperative measures, like taking the close stitches of the mucosa to the skin and a little close by, and then with a good healing of this margin, and also properly cutting the size of the diameter of the stoma, and properly applying the stoma, and you need to stretch the skin nicely and apply the gum or the paste. Whenever you apply, you need to retract all the skin around, and you need to apply the pressure for about a minute after the application of the stoma paste, and then you need to apply the bag. So that is very important. And then also, normally these disc and bags, they last for about 5 days, and bags can be reusable many times. So that is an important measure. So it can be intraoperative and also post-operative, and choosing the site is very important. So next question is from Sirish. Dr. Sirish, sir, how frequently they should change the bag? So normally, if you have got a good stoma, then many times the patient, they can keep it for about 5 days and 7 days. So there should not be air-filled gap, and there should not be seepage of the content. Then it will be a good thing. Probably the first one and second questions, the answers will remain the same. What is the treatment for excoriation? See, excoriation happens very bad whenever there is a contact of this the ileal content. Whereas stoma, the colonic content, usually they are formed thing, and there will be less contact with the skin, and only our intestinal mucosa can tolerate these chemicals. So not the other things. So that the skin excoriations are very high. Especially ileum means it will be most of the time temporary diversion. It's a manageable, and with the proper applicants you can manage. Then okay, then I think the questions are almost. Yeah, there are a few questions. It also individual. Then Dr. PM, I don't know the full name. You said mucocutaneous suturing with non-absorbable sutures. I think absorbable vicryl or PDS is also enough, right, sir? See, normally all this, absorbable sutures, they dissolve by hydrolysis. When the content of the becomes more watery and the stools becoming watery, then this vicryl and PDS dissolves faster. But we don't want to for them to dissolve faster, but we want something, good which stays and where the knots fits properly and where they stay longer. Probably once the mucocutaneous junction seals, say, don't remove the sutures at least for about 2 to 3 weeks. Then by the time the mucocutaneous junction will form well, and then better to use a non-absorbable. So it looks that I have answered questions. If anything, if I left, I will answer. I think it looks like that I have answered all the questions. So if any other questions.
Yes, sir. So thank you very much, trainees and faculty members for joining the session. Thank you, sir.
Thank you, sir. Bye, sir. Thank you.